So folks, for those who came, late, who've just joined, it is our pleasure to introduce to you today Dr. John Mink. Dr. Mink, is a hardcore Washington University of Louisville, neuroscience, guy, and did his MD PhD there, and then did his child neurology training at St. Louis Children's and Washington University, and then did a fellowship in movement disorders. Probably one of the first people in child neurology that actually, I think, probably did a kind of a formal sort of a fellowship with Joel Perlmutter, and and so got some terrific training there, and then basically stayed on faculty at Washington University, St. Louis for a period of time, and then was hired, by Robert Griggs to Rochester, and has been the chief and the of child neurology there. And under his, obviously, auspices, the division has just grown tremendously. And he also serves as the vice chair of the very large department of neurology at Rochester. And you all know that he has been a very big figure in the Child Neurology Society. I think it has been at a very young, I think very close to finishing his training, he was asked to give the Bernard Sachs lecture, and I remember, and then has been the president of the Child Neurology Society, now serving in a big role with the international, with ICNA also. And his achievements are too many to count. He has written the book for movement disorders in pediatrics, and probably, and I think probably wrote the first, I think one of the first papers. John, correct me if I'm wrong, on masturbation in a pediatric patient that was a stereotypic behavior. And actually, I think that may have been one of my patients actually that we saw in the fellows clinic. And so, yeah, and so he wrote that along with, I think, Jeff Neal. Right. He published that paper. So, and then obviously since then we all learned a lot about that. But I mean, his contributions have just been terrific. So I could not be more happy. And on behalf of our division, Mike Soule and Chris Barton, to introduce Jonathan Mink to all of us. John, thanks very much.
Well, thanks, Vinay, and that's very kind. If there's time later, I'll tell you all the things I learned from Vinay when he was a junior resident to me. But we probably don't have time for that right now. So thanks for the invitation. I'm going to talk about chorea. And I'm going to talk about, oh, I lost my disclosure. There it is. So I've got some disclosures. The only thing that's really relevant to my talk is I'm a central rater in a current clinical trial of deutetrabenazine for dyskinetic cerebral palsy that is sponsored by Teva. Otherwise, my other potential conflicts are not related to chorea at all, mostly related to gene therapy and the NCLs. So I'm going to define, or I'm going to try to define chorea for you. I'm going to talk about the phenomenology, talk a little bit about differential diagnosis. I want to focus a bit on Sydenham chorea because that's still the most common single cause of chorea in children in the United States and probably worldwide. And then I want to talk about treatment options for chorea. So chorea, it's a Greek term, literally it means dance-like. And chorea, usually, like most movement disorders, to define it, we put a lot of adjectives together, and we hope that those adjectives will give someone a picture of what it looks like. But really, I'll show you some videos later. Really, it's one of those things that you have to be able to see the spatial and temporal properties of the movements. So they're random appearing sequences of one or more discrete involuntary movements, or sometimes they look like movement fragments, and I'll show you some video examples of those. They appear random because you can't predict when they're going to happen, how long each movement's going to last, the direction, or the anatomic location, though in many patients you do see a pattern of recurring movements of a certain type. It's just that it's not stereotyped. You can't predict at any one moment which movement's going to occur. Each movement has a very distinct start and stop, but sometimes they're difficult to identify. Some chorea looks flowing and some looks jerky. And jerky chorea, it's a lot easier to identify the individual movements. In that, that's more flowing. That's harder, and I'll show you again video examples of both. Depending on the etiology, but people who have chorea as their only neurologic manifestation very often have motor impersistence. They have trouble maintaining a posture. We often see this with tongue protrusion. They have a darting tongue. And most patients with chorea, particularly chorea in isolation, have hypotonia. And again, I'll show you a video example of that. The movements that chorea are often confused with are really two. One is myoclonus. And that's because on average, choreic movements last between 150 and 400 milliseconds. Myoclonus is typically 50 to 100 milliseconds, and it's hard to distinguish the short chorea from the longer myoclonus. But myoclonus, the movements are quick, lightning fast, whereas in people with chorea, there's a broader range of duration of movements. Movements due to myoclonus may appear a little more stereotyped. You see the same muscle over and over and over, whereas in chorea, it's more unpredictable. And then myoclonus may sometimes be rhythmic, whereas chorea never is rhythmic. The other thing we particularly see this from our pediatric colleagues is sometimes patients with chorea are said to be ataxic, and sometimes patients with ataxia are thought to have chorea. And the best distinction is that ataxia never occurs at rest. So if you have your patient lie recumbent and they have some jerky movements, that is almost certainly due to chorea and not ataxia. Whereas ataxia, the more they move, and particularly the more they move across multiple joints, the more you are likely to see the irregularity. And that irregularity is usually rhythmic. So people with dysmetria, certainly attention tremor is rhythmic, but people who have dysmetria, often they will point past and then correct and then point past again. And if you stabilize their joint, so finger, nose, finger testing, if they lock their elbow, you'll see the movements be more stable, whereas someone with chorea, that is not going to make a difference in the movements. And so there are ways that we can, with our exam, distinguish chorea from ataxia, chorea from myoclonus, and then usually the rest is not an issue. They can be distal, they can be proximal movements. They can be large, they can be small. For large amplitude chorea, sometimes we call it balismus or ballism, so large flinging movements. We call that ballism, but really it's just large amplitude chorea. They can be intermittent movements or they can be continuous. And again, I'll show you video examples. Sometimes people with flowing movements are said to have choreoathetosis. I think it's really just a variant of chorea. Chorea fluctuates with state as people get more activated, as they get more excited, as they maintain postures, you see more chorea. Premonitory urge is rare, whereas tics, premonitory urge is common. Most people with chorea don't even complain about their movements. In fact, often they don't even know about their movements. What they know is they're clumsy, they bump into things, they might have bruises on them, but they don't say, oh, I've got twitches that I can't control. And although involuntary, chorea can be sometimes normal. So a normal 6-month-old who you get giggling and smiling, they have chorea. A toddler, very often, you'll see in their movements, there's a little bit of chorea, and very often in younger children, 4, 5, 6 years of age, particularly those who might have some ADHD symptoms or other kinds of variations in development, sometimes they've got a little chorea too. And so it can be completely normal in some settings. Often people use the term chorea form. If chorea means dance-like, chorea form means dance-like. And basically chorea form, although people often use it to refer to smaller amplitude movements, what they're really saying is, I'm not quite sure I want to commit. It's like saying seizure-like activity. choreiform means I'm not quite sure whether it's chorea or not. I'm starting to use that word, but basically choreiform is small amplitude chorea. I'm going to go through, so the differential diagnosis, the causes of chorea number somewhere between 100 and 150 possible causes. And I'm going to just quickly go through a list of causes of chorea to point out that every category of disease we think of in neurology is a category that pertains to chorea. So there's structural, there's toxic, there's metabolic, there's inflammatory, there's infectious. All of the different etiologies of neurologic disorders are true for chorea. And so structural lesions, usually they are structural in the basal ganglia. And chorea is very uncommon following a large stroke, but in small, particularly small multifocal strokes that you might see in vasculitis, or you might see in a patient with moyamoya disease, or a patient with microemboli, that may cause chorea. Certainly moyamoya, probably because as the vessels, the neovascularization includes vessels growing through the striatum, that causes some dysfunction that manifests as chorea. Sometimes vascular malformations. Sometimes you get a Steele syndrome, and so you get decreased perfusion of the striatum and that cause chorea. Hemorrhage, rare, but particularly hemorrhage in the subthalamic nucleus. We see some kids with post-pump chorea, so after cardiopulmonary bypass or after ECMO sometimes, we'll see chorea. Mass lesions are very uncommon to cause chorea, but they might. We see a small percentage of children with cerebral palsy who have a choreoathetoid form of cerebral palsy, and then after trauma, but usually that trauma leads to either ischemia or hemorrhage that can cause chorea. One of the things we think about very commonly, because Sydenham chorea still is the most prevalent form of isolated chorea, or chorea is the only neurologic symptom worldwide and in the US. So we think about Sydenham chorea and we think about other autoimmune disorders. So anti-NMDA receptor antibody syndrome, although technically the movements we see with that are more stereotyped than chorea, they look very much like chorea. And then there are other things, basal ganglia encephalitis, where you can get anti-dopamine receptor antibodies or other anti-basal ganglia antibodies can present with chorea. Certainly lupus and associated or unassociated antiphospholipid antibody syndrome. And once in a while, ADEM will present as chorea, but that's also much less common than the others. With infections, HIV, particularly at the time of seroconversion, so the initial manifestations. Fortunately, we don't see this much in the US, but children with acquired HIV may have chorea as their heralding symptom. And then with all the viral encephalitides, we can sometimes see chorea. And I have a list here of things, though it's much less common, and most of the time encephalitis presents with the classic features, fever, altered level of consciousness, seizures, and then they may also have chorea. Mycoplasma, hard to prove, hard to rule out, has been associated with a lot of things, but I think there is fairly good evidence that mycoplasma infections, particularly when they lead to a vasculitis, can result in chorea. Lyme disease, it's low on the list of neurologic symptoms that can be caused by Lyme. Toxo is another thing that can sometimes happen to cause chorea. All of the metabolic disorders that cause chorea, they're almost never in isolation. So you can get chorea in patients who are either hypo or hyperglycemic, hypo or hypernatremic. They, though, usually, if they're hypoglycemic, in addition to the chorea, they're likely to have altered level of consciousness. They're likely to have seizures. Same with hyperglycemia, hypernatremia, usually have altered level of consciousness, and the hyper and hypocalcemia conditions as well. The chorea can happen, but it's usually in association with other things. And then finally, hyperthyroidism, which is something to consider. But if your patient is not tachycardic, if your patient doesn't have other systemic manifestations of hyperthyroidism, they're very unlikely to have that be the cause of their chorea. Drugs. So drugs have cause chorea in multiple different ways. Things that activate dopamine or release dopamine in high doses, so typically we're talking overdoses, can cause chorea. So methylphenidate, amphetamines, again, where we usually see chorea as a manifestation is someone who gets into their sibling's dose or bottle of a prescribed medication and they take too much and they will have chorea. We certainly see that with recreational drugs, particularly cocaine and cocaine derivatives, where children may get into it and their main manifestation, aside from being hyper alert, is they'll have chorea. High doses, and again, this is usually dose dependent. So sodium channel blockers, phenytoin, carbamazepine, tiagabine are the best described, but any anti-epileptic that acts at sodium channels in high doses can cause chorea. Calcium channel blockers can cause chorea. Antimuscarinics, we most commonly see this in neurology with trihexyphenidyl, used to treat dystonia. Very often the side effect of that is some jerky movements that we call chorea. And then really almost anything that can cause sedation can also cause chorea. Indirect mechanisms, which is due to dopamine receptor supersensitivity, we commonly see this with dopamine blocking agents, either with withdrawal, so withdrawal emergent dyskinesia, which is often chorea, or some of the tardive syndromes are chorea. And then using, particularly treating patients with Parkinson's disease or Parkinsonism with levodopa or dopamine agonists, sometimes as a side effect, you can get this. Oral contraceptives can sometimes cause chorea, but usually that's in patients who have a personal history of Sydenham chorea, and I'll come back to that. We can see chorea particularly in association with polypharmacy for either psychiatric or epileptic conditions. Sometimes can see it with selective serotonin reuptake inhibitors, but I think most of what's described in the literature is really myoclonus and not chorea. And valproate sometimes can cause chorea, but we also use it to treat chorea. Toxins. Carbon monoxide poisoning has a predilection to affecting the globus pallidus and substantia nigra, and there can be, after the patient recovers from the acute loss of consciousness, they can often have chorea. Carbon disulfide can do it. Disulfiram, which is antabuse. We don't see children using that in the setting of alcohol dependence, but it can do it. Methanol, aside from blindness, can cause chorea. Manganese, toluene. So all of these toxins that we see almost never, but they can present with chorea. And then there are psychogenic or functional choreas, but those individuals, their movements, if you really look at them, they are always somewhat atypical for what we normally see with chorea. So those are all the acquired ones. Now let's talk a little bit about the genetic causes of chorea. And here the list is just getting, it seems like every week there's a newly described gene that is associated with a movement disorder, and sometimes that's chorea. There are some where chorea is the only feature or the initial feature. The one we probably think about the most is benign hereditary chorea, which is due to mutations in the NKX2.1 gene. This is also associated with hypothyroidism and lung disease. We're learning more and more about this condition and risk for developing adult lung disease as well, emphysema or even lung cancer. But this can present in childhood. Usually it's autosomal dominant. We're learning more about ADCY5 related dyskinesia. This can cause either a paroxysmal or a continuous chorea. And I'm not going to go through everything here, just to point out a couple of things. Huntington disease in children doesn't cause chorea, but in older adolescents it can. And so after about 14 or 15 years of age, if you see a child with new onset of a subacute chorea, you have to start thinking about whether it might be Huntington disease. Whereas a 4 or 5-year-old with chorea, Huntington disease is just not in the differential diagnosis. But ataxia-telangiectasia is. So although the prominent part of that name is ataxia-telangiectasia, many patients with AT have chorea as their primary and initial movement disorder. And that's also true for patients with ataxia with oculomotor apraxia. Friedreich ataxia may also present with chorea more than ataxia. And then there's a variety of paroxysmal dyskinesias that can have chorea as their primary feature. Common additional features, so GLUT1 deficiency, and this is almost never in the babies who have infantile spasms and severe developmental disability. This is usually in the older onset individuals who have, they might have mild ataxia, they might have some chorea, or they may have episodic exercise-induced chorea. Creatine deficiency syndrome, you can read the other things here. So there are lots of things, probably FOXG1, although FOXG1 is never chorea in isolation, but that's one where chorea is very prominent. And then GNA01 is another one where we commonly see chorea early on, and then they develop their encephalopathy, their epilepsy. And then it's sometimes present in a host of other disorders. And the paroxysmal disorders I have at the bottom of the list, these are more commonly dystonia, but they can sometimes present with chorea. And most of these other conditions, much more likely to be dystonia, but chorea can sometimes be present in things like PCAN or even dentatorubral-palato-Lewisian atrophy or DERPLA can have chorea as the primary feature, but it's almost never the only feature. And so we think about, is it only chorea? What else comes with it? Still in the age of widespread genetic testing, knowing the differential diagnosis, knowing the phenomenology is really important because we always find variations of uncertain significance, and very often they don't fit with the condition. So knowing this is important. Okay. I want to talk about Sydenham Chorea because it's still not only something that we see, in programs the size of yours or ours. We probably see 2 or 3 cases a year. There's some years when we seem to see more. Other years we've seen less. More common in the spring, but it's still something that is kind of bread and butter pediatric neurology. Because of the derivation of the word and the relation to dancing, there's been this constant interplay between the term chorea and the terms applied to dancing. Paracelsus was probably the first to use the term chorea, and he likened what people with chorea did to what certain religious fanatics would do as they would go to the healing shrine of St. Vitus, and they would have these frenzied dances that they would do in front of the shrine of St. Vitus. And so those are often called St. Vitus dance. Though many of the individuals who went to the shrine of St. Vitus actually had chorea, because St. Vitus, as I'll tell you, is the patron saint of choreics. And so initially, St. Vitus was designated as the protector of the faithful from having dancing mania. So people would go and they would voluntarily dance, but also people who had chorea would often go to the shrine of St. Vitus. So who was St. Vitus, otherwise known in some parts of the world as St. Guy? He, around 303 in the Common Era, he was imprisoned. He was thrown to the lions. He was later boiled in oil. He seemed to be quite resilient, and then ultimately succumbed. And he was became a saint. And again, in medieval Germany, particularly dancing as a statue would ensure health. Saint Vitus is the patron saint of dancers and choreics, but also epileptics and actors and comedians. And my favorite is he's the patron saint of those who oversleep. We could all use a little of that sometimes. Sir Thomas Sydenham detailed an epidemic febrile illness in 1685. Probably that epidemic febrile illness was due to grade A beta hemolytic strep, but we don't really know because it was 1685. And he described many of these individuals as having St. Vitus dance. Interesting, again, 1600s, he attributed this to some humor falling on the nerves. And eventually this came to be known as Sydenham Chorea, but it wasn't until the 1900s that we really had evidence that this was due to some humor falling on the nerves, that it's likely to be an autoimmune post-infectious process. I like this description. I'm just going to pull out a couple of things. So this is from Sydenham's description in 1686. It's kind of a convulsion which attacks boys and girls from the 10th year to the time of puberty. So this is generally a pre-pubertal onset condition. The hand cannot be steady for a moment. It passes from one position to another by a convulsive movement, however much the patient may strive to the contrary. Before he can raise a cup to his lips, and I'll show you a video, he makes as many gesticulations as a mountebank. Since he does not move it in a straight line, but has his hand drawn aside by spasms until some good fortune, he brings it at last to his mouth, and then gulps it off at once, so suddenly and so greedily as to look as if he were trying to amuse the lookers on. And so this captures the idea that people's voluntary movements can still happen despite the superimposed chorea. And there's this sense of almost incorporating these choreic movements into the normal behavioral repertoire. So again, it's a beautiful description, I think, of what we see with chorea. So it's in 1956 that we had the first clear association with group A beta hemolytic strep. We know that many children have strep. The average 10-year-old has 3 strep infections a year, 2 of which are asymptomatic. But some develop acute rheumatic fever. And somewhere between 10 and 40% of children with acute rheumatic fever develop chorea. I'm not going to go into all the Jones criteria, but it's the only major Jones criteria where that's the only one you need to diagnose acute rheumatic fever. Some have other manifestations, but many of them have only chorea. Typically 5 to 15 years of age, typically female predominance after the age of 10. And fewer than half have simultaneous arthritis or carditis or other manifestations of acute rheumatic fever. So I'm going to show 3 videos of patients with acute rheumatic fever. This is a girl that maybe Vinay remembers, because this was when I was a PGY 4 resident. So maybe Vinay, you were over at Barnes. But this is a girl who has Sydenham Chorea back when we admitted patients to the hospital with this condition. I just want you to see her movements. So her movements are jerky. When she's holding her arms out, you can see she had a little trunk jerk there. She's very good at trying to incorporate her involuntary movements into more voluntary appearing patterns. And again, you'll see her movements are intermittent. The video is a little pixelated, but you'll notice that she has bruises all over her arms, and it has a padded bed because her movements are sometimes quite violent. This is a great way to bring out chorea in your neurologic exam, is to have a patient hold their hands up over their head, and you can see that brings out both distal and proximal movements. And again, her movements, her choreic movements, are quite discrete. This is an old 16mm movie that I digitized. This is from Vinay and and probably Mike Sowell's Guru. This is from Philip Dodge. And this is a patient that he filmed in the 1960s when he was at Mass General. And I show this because it's just a beautiful example. First of all, you'll see this young man has more of a flowing movement pattern. You'll see he's also covered with bruises. And you'll see how good he is at compensating and being able to do a voluntary movement despite this. So it's a little irregular because it was initially a 16mm movie, but you can see he's got nearly continuous movements. Some people would call this choreoathetosis. I think athetosis has a specific meaning, and so I would still call this chorea. You'll notice here he's being asked to reach out and touch the examiner's finger. That might indeed be Dr. Dodge. And you can see his movements are really very accurate. So he can target his movements quite well, even though there might be some superimposed chorea. Oh, I'm sorry, this doesn't have it, but he's able to reach out for that cup and bring it up to his mouth and drink the water without spilling much, despite his whole body having this continuous flowing movements. And then finally, Here's a girl from more recently. She also has Sydenham Chorea, and here she's being examined in our emergency department by one of my colleagues. You can see she's got, some of her movements are a little more flowing, some are a little more discrete. She looks, although tone is something you feel and not see, but she looks hypotonic. She kind of has that slumped appearance. This is Dr. David Wong, who's now retired. He's now demonstrating the so-called milkmaid's grasp. Milkmaid's grasp is chorea that you feel. And with sustained squeezing of his fingers, you can feel these involuntary contractions that feel like milking the cow. You can see she also has bruises. So people with chorea are constantly bumping into things, but again, they don't complain about the involuntary movement, they complain about bumping into things. And you'll see in a moment a couple of other things. So another thing we see in patients with chorea, here's the hypotonia, and again, you can kind of see she's clearly not hypertonic. You just have to take my word that she has low tone. You can see she's pretty good at relaxing there. And then every once in a while, there'll be a catch. And that's not a spastic catch, but that's because of the superimposed choreic jerk. There's a phenomenon we call the hung up knee jerk or hung up stretch reflex. And sometimes if you keep tapping on the tendon, you'll see every once in a while, it will coincide with a jerk. And there you go. So sometimes you'll elicit, and there you get one that's even more sustained. So sometimes you'll get that, it'll elicit a choreic jerk that will be a sustained contraction. So those are the things we commonly see with that. And then the so-called darting tongue, which we're not going to see here, but with tongue protrusion, people have chorea. And you can see for her, this affects her ability to sit upright. She's got axial as well as appendicular chorea. Okay, so those are examples of this. So Sydenham chorea, you get the classic triad of chorea, hypotonia, and emotional lability. Almost everyone with Sydenham chorea, if you ask the parents, they'll report that prior to the movements, they seemed silly or had emotional lability. They'd go from laughing to crying for no clear reason. Many of them are reported to be clumsy. You'll hear the story that they kept dropping dishes when they were clearing the table. And so it's often they present with emotional instability and clumsiness, but when you really look at them, they have chorea, and the emotional lability is probably sometimes referred to as emotional chorea. It is typically asymmetric. Most neurologic syndromes are typically asymmetric, even those that have bilateral involvement. But up to 20% of patients with Sydenham chorea have unilateral chorea. Chorea affects every voluntary muscle or can affect every voluntary muscle. And so there's often dysarthria because of involvement of the tongue and the face and sometimes the anterior oropharynx as well. You can have oculomotor chorea. There can be darting eye movements with difficulty of fixation, the so-called darting tongue. All of these there's particular names in the literature, but they're all just referring to chorea. Likewise, the hung up reflex. And the motor impersistence, when they're holding a posture and they suddenly relax that posture or they can't keep their tongue protruded, is because of the intrusion of a choreic jerk. Sometimes the behavioral and psychiatric manifestations can be really striking. And this is, I'll come back to that. First, let's talk about what else comes with it. So this is a paper out of a neuroradiology journal of all things, but it was a nice series of patients with Sydenham chorea who presented for imaging and x-ray studies. And what I want to point out here is you can just see here from the 19 individuals, the female predominance and what came with the first attack. CO is chorea, AR is arthritis, CA is carditis. So you can see the great majority of patients here have only chorea. The next most common is carditis, and then a small number have arthritis. And then those who had recurrence of their chorea almost all had, recurrence of their acute rheumatic fever symptoms. Almost all had only chorea as their recurrent symptom. Arthralgia, about 70% can have arthralgia. It's the classic migratory arthralgia you see in acute rheumatic fever, and on average it lasts 4 to 6 weeks. Up to 45% have carditis during the first attack. Erythema marginatum is quite uncommon. Turns out there are different serotypes of the group A beta hemolytic strep, and some serotypes are more likely to result in carditis, some are more likely to result in chorea. Subcutaneous nodules, and then you get the other things. Though some will have epistaxis, some will have pneumonitis or pleuritis. That's probably also a sequela of a more substantial strep infection. And then very, very, very rarely you can have an encephalitis picture that is a post-streptococcal encephalitis, but that's incredibly uncommon. I talked about the very long differential diagnosis we have for chorea, but for subacute onset chorea in an otherwise healthy child, particularly with the other manifestations of hypotonia and some emotional lability, you have to think about other autoimmune disorders. So probably the big three in children in North America are chorea, lupus, and drug ingestions. Those are probably the three most common. And then, of course, you have to think about acute infections. Laboratory studies to really look for Sydenham chorea. Many people will still do anti-streptolysin O or anti-DNase B titers. I think they are of minimal help. And the reason I think they're of minimal help is, as I said before, the average 10-year-old has 3 strep infections a year. And so you could argue that the average 10-year-old always has an elevation of these antibodies. And so if you see elevation, that does not mean that it means they've had a strep infection within the past several months, but it doesn't tell you that that was the etiology of their chorea. And so I don't really measure these anymore, though others do. The main thing you want to look for is, do they have evidence for carditis? If they have carditis, that helps nail the diagnosis, but also the main sequelae of acute rheumatic fever are impacts on the heart. And so echocardiography, I think, is indicated in any child with a subacute onset of chorea. And EKG is often the earliest sign. You see a prolonged PR interval, though it's really the valvular abnormalities that we're most concerned about. Head MRI scan is almost always normal in individuals with Sydenham chorea, but because the differential diagnosis is so broad, and because anyone who has a unilateral chorea deserves to be imaged, in most children where I think it's Sydenham chorea, I will do head imaging. I said this already, I'll say it again, that psychiatric manifestations are common, emotional lability being the most common, but some can have obsessive compulsive symptoms. Many of them, along with their emotional lability, are distractible or inattentive. Some become impulsive, so they may have ADHD-like symptoms. This is from a paper from Susan Sweeto. Some of you might know that name because she was the originator of the PANDAS hypothesis. The PANDAS hypothesis arose from this observation that children with Sydenham chorea can very often have OCD, anxiety, ADHD as manifestations, and so could the sequelae of strep also include OCD? I'm not going to talk much further about that, but we're happy to take questions later. But this is just a description of 11 individuals who had Sydenham chorea and the description of what their psychological symptoms are. And sometimes they really have profound obsessive compulsive symptoms. And sometimes they have impulsivity and distractibility, and sometimes they have tics. So in 2003, Cheadle reported a large series of individuals with acute rheumatic fever who had tics or OCD or a combination. So this is not a new observation, but it's one that has gained increasing attention over the past 30 years or so. Here are other descriptions. And so more description of some of the obsessive compulsive symptoms that you get in these, often just kind of just right-isms, fear of contamination. So how do we make the diagnosis? It's the chorea developing insidiously in the setting of previously good health. Very commonly, they are completely healthy, so it's less common for them to have a clear febrile pharyngitis, for example, and then develop the chorea. Usually they're pretty healthy and then it starts. They almost never have encephalopathy as part of this, so they should be alert. And although there is sometimes a family history of acute rheumatic fever, there's typically not a family history of chorea. And certainly you don't want to get a family history of a progressive disorder. Otherwise, if you do, that tells you this is much more likely to be related to that and not Sydenham. I do a tox screen in almost anybody who has new onset chorea, but if you get the history, they've had it for 4 or 5 weeks, then that's almost certainly not the answer. And then I generally do kind of broad screening. I want to look for red cells. I want to think about the rare possibility of chorea acanthocytosis. Sometimes I'll measure thyroid, but it depends on how ill seeming the child is. So I don't always do these, but for children who come to the hospital because of their chorea, we usually do these things anyhow. Absence of Kaiser-Fleischer rings, chorea. So Wilson disease in children under 10 is liver disease. And so if it's an older teenager, you do have to think about the possibility of Wilson disease. But in a pre-adolescent child, I usually don't check these if I can really convince myself it's Sydenham chorea. I almost always do an ANA. Pregnancy test, because there's a condition, chorea gravidarum, which is usually reactivation of Sydenham chorea. So in an older adolescent, because Sydenham chorea is usually pre-pubertal, if it's someone who is post-pubertal, young woman, I'll often do a pregnancy test just because sometimes you can get it with pregnancy. If they have a throat culture positive for group A beta hemolytic strep, they might be a carrier. It may have nothing to do with this, but certainly if they have a positive throat culture, you want to treat them and then consider follow-up. And then if they have other findings of rheumatic fever, certainly that helps support the diagnosis. For someone who has a new onset of chorea, throat culture is positive in 25 to 40% of them. And the literature tells us that the pharyngitis may precede the onset of chorea by 6 months. And so it's really hard to make a clear association. Streptolizin ASO titer, the anti-streptolizin O, is elevated in about 80% of people with a recent streptococcal infection. And in Sydenham chorea, the problem is that these are reference data that I think are too low based on what we've learned about the commonality of strep infections. But if you get throat culture or ASO titer and elevated anti-DNase, and this should be anti-DNase B antibodies that we check these days, that's pretty good evidence that they've had a strep infection sometime in the past 3 to 6 months. What's the pathology? There's some very old pathology from the turn of the last century, so late 1800s, early 1900s, that show arterial inflammation with some evidence of arteriolar pericapillary degeneration, but it's really not a neurodegenerative disease. You typically see the evidence for inflammation around the blood vessels in the basal ganglia. And ultimately, it's thought that this inflammation leads to dysfunction that leads to excessive dopamine activity or diminished cholinergic activity, and maybe there's some effect on GABA systems too. A lot of this is just kind of hand waving. We don't have much direct evidence for abnormalities in those neurotransmitter systems. There's one study from the mid-1990s that showed on average the caudate, putamen, and globus pallidus were slightly bigger in those with Sydenham chorea versus the controls. This has never been replicated. The increase is small, and it seems to be only during the acute phase, and this requires careful volumetric quantitation. And so in a routine clinical MRI scan, you're never going to see enlargement. In PET studies of those who have active chorea, there's some evidence for hypermetabolic, particularly the striatum. Now, if they're having continuous movements, maybe they're going to have increased blood flow because of the movements and not as a cause. But again, this is something that has been replicated, that SPECT studies and PET studies have shown that there's increased metabolism in the basal ganglia. What causes this? It's almost certainly molecular mimicry. Antibodies that cross-react, that they recognize some antigen on the strep organism that then cross-reacts with something. The M protein cross-reacts with tropomyosin and myosin. The group A carbohydrate antibodies to that cross-react with the myocardial sarcolemma and the subthalamic and caudate nuclei. And so there's again, some evidence for molecular mimicry and cross-reaction, but we don't think it's one specific antibody or one specific antigen that triggers this. Many individuals, as I say, do have anti-basal ganglia antibodies, but again, they're not particularly specific. This region here, it's about 67 kilodaltons or so. You'll often see a band in people with Sydenham Chorea. And if you do histologic studies, you can see that there is immunofluorescence staining and here in the head of the caudate. So most of these studies were taking blood serum from individuals with Sydenham Chorea, then putting it into rat and seeing that it seems to stain not the neurons themselves, but vessels in the areas of the white matter tracts. How do we treat it? Well, there are many children with Sydenham Chorea that I don't treat, at least not treat their chorea. If it's there and is not functionally disabling, we're more likely to have side effects of our treatments than we are to have benefit. And then it's a question of what to use. So most of the literature, most of the evidence we have is for dopamine D2 receptor blocking neuroleptic drugs. So haloperidol, clopramazine, or pimozide can decrease the severity of the choreic movements, but they're not very well tolerated in many patients. Valproic acid is good for treating Sydenham Chorea, but not other choreas. Carbamazepine in one head-to-head study was as effective as valproic acid, but had fewer side effects. But also carbamazepine is really effective primarily in Sydenham Chorea and not in other subacute or chronic choreas. And then corticosteroids. They may shorten the time to recovery, as they do in multiple other post-infectious neurologic disorders. And so here's from, it should be PAZ, P-A-Z, I have a typo here, did a double-blind placebo-controlled trial, well-matched samples, comparing placebo to prednisone in individuals with Sydenham Chorea. On the y-axis here is their chorea score, with high numbers being worse and 0 being no chorea. And this is over the course of weeks. And you can see over the course of 12 weeks here that the recovery was faster in the individuals who got prednisone here in the black compared to those who got placebo. But at the end of 12 weeks, there was no difference between the two groups. And at follow-up after 6 to 9 months, there was no difference between the groups. So the outcome is the same. It speeds recovery a bit, but it doesn't speed the recovery dramatically. I'll treat, sometimes I'm persuaded to treat with prednisone because we know it's an autoimmune disorder and it makes sense to treat the underlying mechanism. But again, if it's mild chorea, I tend not to treat them. If they're having disability, I treat them with prednisone, and I treat them with a symptomatic treatment for their chorea. The most important thing is prophylaxis for acute rheumatic fever. Recurrence is most common in the first 2 years. And if it's recurrence of chorea, that's one thing. But if it's recurrence with rheumatic heart disease, that can be a more significant problem. So the American Heart Association, the American Academy of Pediatrics recommend treatment with prophylaxis at least until age 18 to 21, and then indefinitely if they have rheumatic heart disease. And the reason we treat up to 18 to 21 is that's where the incidence of group A beta hemolytic strep infections falls off dramatically. Almost everyone has a complete remission 2 to 3 months after onset, though some may have persistent clumsiness and incoordination lasting a bit longer. Recurrence rate is 10 to 25%, with a typical interval somewhere in the 1.5 to 2.5 years. And recurrence is most common, particularly in girls and women with oral contraceptives or pregnancy. And then so-called senile chorea, chorea that comes on in older individuals, very often that's also a reactivation of they often have a history of rheumatic chorea. Treatment is kind of unsatisfying. And the reason it's unsatisfying is none of our medicines make it go away completely, and most of our medicines have bothersome side effects. And this is not just Sydenham, this is all choreas. If we have a treatable underlying disease process like hypocalcemia, the prognosis is much better. What we choose depends on the etiology, but we have really very few good studies. There was that one head-to-head comparison of valproate to carbamazepine in Sydenham Chorea, and then we have that one double-blind placebo-controlled trial of prednisone in Sydenham Chorea. Everything else we have is case reports, small series, or relying on people like me saying, well, in my experience, which is only as good as my experience. Probably the most effective across the board in treating chorea are the dopamine depleting agents. So tetrabenazine, the now more recently available tetrabenazine derivatives, valbenazine, deutetrabenazine. Neither of these has been well studied in children. They have a longer half-life and therefore may minimize some of the peak dose side effects. Old-fashioned, and still sometimes I'll do this, but rarely. Reserpine is also a catecholamine depleter, and if you give it with alpha-methylparatyrosine, they have fewer side effects because you can deplete dopamine more selectively than all catecholamines. The next most commonly effective are the D2 receptor blockers and the potent ones. So a lot of people will start with risperidone or an atypical neuroleptic because we've been taught that they have fewer side effects. But for treating chorea, you want D2 potency. And so the atypicals are less potent. You're more likely to get benefit with a low dose of haloperidol, pimozide, chlorpromazine, or any of the other potent or typical neuroleptics than you are with kind of moderate doses of an atypical neuroleptic. But they're okay. The ones that are least atypical, so risperidone, olanzapine, are much less atypical. The true atypicals, quetiapine, which is Seroquel, or clozapine, clozaril, they don't touch chorea at all because they don't occupy D2 receptors at all. Valproate, carbamazepine, probably only effective consistently in Sydenham chorea, but they might be effective in some of the genetic choreas. And then benzodiazepines, we have almost no evidence, but we have a lot of clinical experience. And so clonazepam in particular may be helpful in some individuals. For specific conditions, there are enough case reports of benefit from L-DOPA in patients with benign hereditary chorea that if the chorea is disabling, I will often try L-DOPA. There's an emerging literature that the paroxysmal chorea that you see in ADCY5 mutations might respond to stimulants better than anything else. And then the paroxysmal choreas respond to medications that those paroxysmal dyskinesias respond to. So carbamazepine is the best choice for kinesiogenic dyskinesia. Clonazepam is the best for paroxysmal non-kinesiogenic dyskinesia. And for exertional dyskinesia, which is usually due to GLUT1 deficiency, acetazolamide, or in some cases when it's severe, a ketogenic diet might be beneficial. So that's a whirlwind tour through chorea. Many causes. Most of the causes in the differential diagnosis are not chorea in isolation. And so it's important to think about them to know they exist. But if you have a child who has only chorea, they're much less likely. Though the genetic causes of what we previously thought of as idiopathic chorea are increasingly identified. Sydenham chorea is still the most important cause, being the most prevalent cause, or I guess highest incidence cause. Think about drug ingestion, think about lupus, and then the rest of your evaluation will point you to whether you need to think more serious about genetic causes or not. Often people with chorea, it's annoying and not disabling. And so very many children with kind of mild chorea, I don't treat symptomatically. But if it is causing injury, if it's causing disability, if it's interfering with care, as it is in some children who are more disabled by other movement disorders but have the chorea, there are a number of treatments that might help. Most of our treatments are symptomatic rather than disease modifying, and most are incompletely effective. So our goal is really to have benefit with reduction and symptomatic improvement rather than symptomatic elimination. Dopamine depleters, I think tetrabenazine is probably the best choice for most forms of chorea. D2 receptor blockers are most likely to be effective as a second line. And then other treatments depend on the specific etiology of the chorea. Tetrabenazine, you have to jump through some hoops often to get to insurance to cover it. I'll tell you the trick I use is I can very often get approval for a 1-month supply, and then we have to get approval for ongoing. You can usually get an answer within a month. And if it helps within a month, then you can write your letter of medical necessity. And if it doesn't help within a month, then it's just as good to move on to other things. Children tolerate tetrabenazine really quite well. And so that has increasingly become my first-line treatment. The evidence is emerging, but it's not great. But we don't have any better evidence for most other things. So let me stop there, see if you have any questions.
Hi, John. It's Mike Soul. I just wanted to really thank you for coming to talk to us today. You've really given us a shot in the arm, metaphorically, and it's been great. I really appreciate your talk.
Thanks, I appreciate it. I sent to Mike a copy of a review I wrote with a fellow about a year ago on treatment for chorea that has an exhaustive table, including dosing information and side effects and the literature supporting those choices. But as I said, the literature supporting those choices is really very disappointing. It's a couple of case reports here or a very small open label series of 4 or 5 cases. And because so many of the subacute choreas are self-limited, we don't know if the patients improved because they improved or if they improved because of the medication. Vinay's talking to me, but
Vinay, you're muted if you're talking.
John, you didn't say anything about trihexyphenidyl artane?
Yes, because on average, in most patients, trihexyphenidyl makes chorea worse. And so, I think one of the traps that many people fall into is they think of, here's my list of movement disorder drugs. And this is a patient with a movement disorder. I think I'm going to try these in order of whatever I like most or what makes sense. But trihexyphenidyl is really moderately good for patients with dystonia, but it can often cause chorea, and in patients with chorea often makes their chorea worse. There are some exceptions. I don't know in benign familial chorea. Benign familial chorea, usually dopamine and dopamine agonists will make chorea worse, but in benign familial chorea, it actually seems to help. And so there are always exceptions to our rules. But for chorea, it's really things that reduce dopamine or block or enhance GABAergic transmission. So you either enhance inhibition or you block dopamine. And those are our 2 most consistently effective things. And then those that affect high frequency neuronal firing can sometimes help. And that's why I think the anti-seizure medicines in some forms can be beneficial.
So based on a case that we had a couple of years back, John, if you can try to enlighten us about the natural history of chorea and its course that occurs following hypoxic ischemic encephalopathy, what is the natural history, and that can you see turbulence in that history sometimes? Because we had a patient where this child had moved from Alabama to Kentucky, and there was some question that the neonatologist or the pediatric neurologist had told mom there that she thought the child had had a hypoxic injury, possibly. We saw the child years later. We could not get a clear history about whether, how the chorea started, and we were wondering, is this related to the child's CP, or does the child have some other novel cause? And it eventually turned out that the child had a KMT2B gene mutation. So what I'd like to know from you is, can you tell us about the natural history of chorea following brain injuries, and especially HIE?
Yeah, so neonatal brain injury, isolated choreic cerebral palsy is exceedingly rare. And in those children, they usually have onset of their chorea within the first year of life.
Oh.
To have chorea develop in a 7 or 8 year old with a perinatal hypoxic ischemic birth injury is really, really exceedingly rare. There are a couple exceptions. Sometimes that hypoxic brain injury is related to congenital heart disease, and those children often have heart surgery, and that puts them at risk for developing a post-pump chorea or chorea related to microemboli, but that also tends to be time limited. And so if they had heart surgery when they were 6 months old, and now they have chorea when they're 11, it's really hard to make that link. The other situation in which we do see it, and sometimes it is delayed after, in older children who might have, an acute cardiac arrest or something else that causes hypoxic ischemic brain injury. Usually it's as they're waking up that you'll see the chorea, but that's often time limited as well. Those patients, it's just like the post-anoxic myoclonus you see. It may be very profound as they're regaining, if they regain consciousness, as they're waking up from their injury. But if they survive and it's 2 or 3 years later, it's much likely to be reduced. And so the chorea in particular may be a reflection of irritability in that acute period rather than sustained. The one situation in babies where we see the worst chorea is in kernicterus. And so many babies with kernicterus, certainly preemies, are at increased risk. And they're also at risk, increased risk for brain injury as part of their premature condition. But true kernicterus is the one where we often see the most difficult to treat chorea and the most persistent chorea, whereas kind of garden variety, term infants, hypoxic ischemic brain injury, chorea is a very uncommon thing. I guess the last situation where we see it in infants is in bronchopulmonary dysplasia. There's a small literature on this. Fortunately, we don't see nearly as many babies with BPD as we used to in the pre-surfactant era. But patients with BPD, they probably have chronic hypoxemia, and that probably causes striatal dysfunction or striatal injury. They can have chorea, but that also tends to be self-limited and improving rather than worsening over time.
Hey, Dr. Mink, Chris Barton. So I've gotten a chance to briefly meet you in the past, but I'm one of our people who kind of focus on movement disorders here. So I quite appreciated your talk. I had a couple questions for you. So kind of bouncing off what Dr. Puri's question is. So one challenge that I can definitely see is patients with our who have chorea with other movement disorders associated with brain injuries. And that is a particularly very difficult type of chorea to treat. So the chorea aphatoid cerebral palsy patients who maybe have overlying dystonia. And then, we've had, interestingly enough, a patient about 9 months ago who had really almost a post-pump chorea. We see that so infrequently now. And I know that's also a very difficult type of chorea to treat. I thought your comment about having a benefit with low dose typicals over medium to high dose atypicals, that's actually going to be a huge takeaway for me. But I didn't know, do you see a similar benefit or other medications that have been beneficial for you in those populations?
No, you're right. You know, my experience is like yours, very hard to treat. We try a number of things. Sometimes, you know, for some patients, it's the last medicine I try, which is the one that's most effective, but that might be because I try it as the chorea is improving. So post-pump is very hard, but the good news is it's usually time limited. The complex mixed movement disorders, the hardest thing there is figuring out what is the major source of disability for the child and trying to focus on that. Chorea is disturbing to watch. So parents, teachers, therapists, doctors, you know, they look uncomfortable. And often they have facial grimacing and they just look uncomfortable. But if you really look at it objectively, it may not be causing any functional limitation, whereas the dystonia that they have along with it may be causing more substantial functional limitation. And so that's, I think, one of our biggest challenges in the patients with mixed movement disorders is to try to prioritize. And very often the truth is they've got 3 different things, all of which are impacting their function, but you don't want to address all 3 of them simultaneously or you'll end up confusing yourself. And so I often put chorea lower down on the list. But sometimes, you know, someone who's got both chorea and very mobile dystonia, I'll sometimes, that's the patient where I'll start with clonazepam, because clonazepam can help with both.
Yeah, and I'm appreciate hearing that, because that's been my strategy, at least right now too, is to try benzos to see benefit.
I didn't include the video, but I have a video I have of a patient that makes a really good teaching point. This child has GNA01 mutation, who presented with primarily chorea and was very frustrated because he couldn't do things because he was always wiggling. And I made that chorea stop with clonazepam.
Wow.
Completely.
Okay.
And his mom sent me a video where she had to prop up his head so he can drink from his sippy cup because I made him so tired and ataxic with the clonazepam that he could barely keep his eyes open. I made the chorea stop, but he was more disabled as a side effect from the medication than he was from the chorea. So then we moved on to tetrabenazine, which helped him quite a bit for a couple of years. And then he ultimately went on to deep brain stimulation because he developed other manifestations. And so, you know, general anesthesia is a great way to make chorea go away, except it's not a great way to make chorea go away. So again, you know, we have to always consider what's our goal. We want to maximize function and quality of life. And sometimes the best way to do that is to help the family learn some coping strategies rather than having our goal that we want to suppress the movements.
Dr. Mink, a question. There is probably some few articles about using the Capra low dose 10 per kilo, especially for the HI babies who are having the chorea. What's your experience with that?
Not very good. You know, I think that there are a couple of problems. One is that sometimes what's described in the literature as chorea isn't chorea.
Okay.
The other thing is, you know, again, in those descriptions, it's open label, case report, or case series. You know, it's not a crazy thing to try, but my experience has been that it's very dissatisfying. Sometimes people try Keppra because we do it all the time, vitamin K. It's easy, it generally doesn't cause side effects. And sometimes, you know, we all do this, that you prescribe something, the movement gets better, and then you draw a cause-effect relationship, but in reality, it may be a complete coincidence. So I don't, you know, all these open label case series, all of these single case reports, I find them as things that are interesting to stimulate our thinking, but not something that I rely on as evidence.
Correct. That's what was our experience as well. It has not been effective at all.
Yeah.
Thank you.
I'll keep picking your brain, and we can stay on here a couple more minutes if you have time, Dr. Mink.
Yeah, I could do another 5 minutes or so.
Perfect. I'm the next lecturer, so we'll take as much time.
And I'm on service, so I have to go check to see what's going on with the...
Perfect. So I'll ask 2 questions. Apologize if they spur conversation, but in terms of patients who have underlying chorea, particularly chorea with other movement disorders, one thing that I have found that is tricky is the approach to genetic testing.
Yeah.
And I found that it can be really hard because, we have dystonia panels, we have some of these other things. There's not great chorea panels. Now, with the, we use Invitae a lot here. And so I've started using the CP Mimickers panel just because it has a lot of neurotransmitter disorders and stuff on it. I didn't know if you were doing kind of a similar approach before going to whole genome.
Yeah. So like you, it is a little frustrating because there's not a chorea panel. Enough of the things on the dystonia panel can manifest with chorea that I think about that, but a lot of the genetic choreas have other manifestations that can help tip us off. So ataxia-telangiectate, Friedreich, those things, there are almost always other findings with them. Sure. The Invitae CP panel is nice, but it's also very limited because a lot of our patients don't meet their criteria for what they're, this is sponsored by a drug company that is looking for patients that have neurotransmitter disorders. There used to be a panel that was sponsored by a company that was looking for patients with paroxysmal dyskinesias, and then their preliminary studies failed, and so they were no longer interested in sponsoring that. And so, they're looking for a particular patient type. I take advantage of it when I can, but then there's, I kind of have my big list, and increasingly ADCY5, GNA01, and then NKX2, the thyroid transcription factor or the benign hereditary chorea gene are things that I almost always check for if it's a child who has no other symptoms. If they've got intellectual disability and chorea, I will pretty much start with a microarray and then go to whole exome, because if it's significant intellectual disability, there's enough of a chance there's going to be copy number variation, particularly think about things like FOXG1 and other things that may have a more profound effect on cognitive function, but also they have chorea. And so it's not very satisfying, but it is something where we do have ways to get there.
Sure. And then the last question, and I know this is a whole talk in itself. I know at Child Neurology Society meeting in the fall, I know there was a lot of discussion, particularly, I think you were involved in some discussion too, just how we're seeing kind of a mix of post-viral or post-strep kind of late onset tics versus chorea, particularly in adolescents. And I feel like in our practice, we've seen, a huge uptick in these kind of atypical Tourette syndrome patients, right? That are just presenting, maybe had very minimal tics, but now they're having this kind of explosive onset ages 12 to 16. I feel like I've seen.
Yes. There's an epidemic of that. Yes.
Yeah, it's huge right now. And I think it's most likely related to a lot of the stress and stuff in our society, but distinguishing those patients from Sydenham's patients, I think is sometimes tricky.
Yeah.
And required
because someone always gets an ASO titer, and
and then they come and see us.
It's 1 to 400,
Yeah.
and then you have to explain that.
Yeah.
Like you, we've seen a lot of adolescents with sudden onset of explosive tics, and some of them are typical tics. They've got a premonitory urge, and they are in patients who have a personal history of OCD and anxiety and ADHD. So you can say, well, yeah, it just, something lowered their threshold. Now they've got tics. And then the other half are functional. And again, it depends on what's coming to see you. It's a different topic. I find the evidence in support of PANS and PANDAS to be weak to non-existent. Whereas the evidence, to support Sydenham Chorea is moderate. If someone were to hypothesize today that after strep you can get chorea, and the way we do it is we look to see if they have elevation in ASO titers, I would say they're crazy, that there's no way to prove it. But fortunately, we have hundreds of years of experience of a link between, something that we now know as group A beta hemolytic strep and then sequelae. Whereas the other things, particularly, the kids who just aren't doing well, often PANS is raised as a question. But if you don't have OCD or restrictive eating disorder and it didn't come on overnight, you don't have PANS. And so what is it? And I think, stressors, everybody's stressed, and everybody's stressed. And even if they say, I don't have any stress, everybody's stressed.
Yeah, I stopped asking my patients if they have any stress because it's a stupid. I tell them I used to ask that question, but I find it stupid because we're in the most stressful time period of my lifetime. So,
Ken Mack, who's at Mayo Clinic, a headache guy, taught me never ask a teenager, tell me about the stress in your life, because teenagers always say, I'm not stressed. He says, so you must be pretty busy. Tell me about all the things that you're doing. And then you get an idea of, all the things that this kid is doing now. Right now, tell me all about all the things you're not able to do.
yeah.
Yeah, it is interesting. All right, so thanks for the invitation. I do have to run and see.
Thank you very much. We really appreciate your time.
All right, take care.
Thanks,
Bye-bye.
John. Take care.